Removal of embedded foreign body, vestibule of mouth, simple. Complicated. The vestibule consists of the mucosal and submucosal tissue of the lips and cheeks within the oral cavity, not including the dentoalveolar structures. The physician may simply grasp the object with an instrument and remove it, or incisions may be made to free the object and remove it. Complicated removal of a large foreign body or one that is difficult to access is done. Removal of embedded foreign body from dentoalveolar structures, soft tissues. The physician removes a foreign body embedded in the soft tissue of the dental alveolus, gingival or alveolar mucosa. The physician may simply grasp the object with an instrument and remove it. If the object is further embedded, incisions may be made in the mucosa near the object to remove it. Sutures may be necessary. Removal of embedded foreign body from dentoalveolar structures, bone. The physician removes a foreign body embedded in the bone of dentoalveolar structures. The physician may simply grasp the object with an instrument and remove it. If the object is further embedded, mucosal incisions may be made to reach the foreign body in the bone, which is removed, possibly with drills or osteotomes as necessary. The incision is sutured simply. Removal of peritoneal foreign body from peritoneal cavity. The physician removes a foreign body from the abdominal cavity. The physician makes an abdominal incision and explores the abdominal cavity. The foreign body is identified and removed. The incision is closed. Removal of foreign body from pharynx. The physician removes a foreign body from the pharynx. The physician uses an intraoral approach with the aid of a tongue blade to visualize the foreign body. The foreign body is grasped with forceps and removed. Removal of foreign body in scrotum. The physician makes an incision in the scrotum for the purpose of foreign body removal. This may involve one or both sides of the scrotum and may be done through one or two incisions and may require incisions through the various layers of tissues to expose and locate the object. The foreign body is identified and isolated and removed with care to avoid damaging tissues in the scrotum. A drain may be placed in the scrotum and the incisions closed in successive layers of sutures. Removal foreign body from deep penile tissue, e.g., plastic implant. The physician removes a foreign body from deep within the shaft of the penis by making an incision and dissecting the tissues. The foreign body, usually a penile implant, is localized and removed. The resulting defect is closed with layered sutures. Removal of fecal impaction or foreign body under anesthesia. The physician removes a foreign body or fecal impaction under anesthesia. The physician performs removal of a foreign body or fecal impaction manually or with an instrument under the relaxation of anesthesia. Is it appropriate to report CPT code 45915, removal of fecal impaction or foreign body, separate procedure, under anesthesia, when conscious sedation is used? No. CPT code 45915 is intended to be reported for fecal impaction or foreign body removals only when performed under general anesthesia. The CPT code descriptors that include the phrase requiring anesthesia or under anesthesia indicate that the work involved in that specific procedure requires the use of general anesthesia. Therefore, it would not be appropriate to report code 45915 if general anesthesia is not Prov. Fecal impaction or foreign body removal performed with other anesthetics is considered inclusive to the appropriate evaluation and management service code. Removal of impacted vaginal foreign body under anesthesia, other than local. Using a vaginal speculum, the physician removes a foreign body lodged in the vagina. During the procedure, the patient is under general anesthesia because of the patient's inability to tolerate the procedure while awake, as in the case of a young child, or due to the type or size of the object being removed. For removal without anesthesia of an impacted vaginal foreign body, use the appropriate evaluation and management code. Removal of skin tags. Removal of skin tags, multiple fibrocutaneous tags, any area, up to and including 15 lesions. Each additional 10 lesions, or part thereof. The physician uses sharp excision with scissors or scalpel, chemical cautery, electrical cautery, ligature or strangulation, or any combination of these methods. For removal of skin tags by any method, use codes 11200 and 11201. For the first 15 skin tags removed, use code 11200. For each additional 10 skin tags removed, also report code 11201. For example, if you removed 35 skin tags, then you would submit codes 11200, 11201 and 11201. If skin tags are removed by shaving, which code would be more appropriate? 11200 for removal of skin tags. Oregon 11300 for shaving of epidermal/dermal lesions. Since codes 11200 and 11201 are diagnosis specific for removal of skin tags, and removal includes scissoring or any sharp method, these codes should be reported for removal of skin tags that have been shaved. Removal of prosthetic material or mesh, abdominal wall for infection, e.g., for chronic or recurrent mesh infection or necrotizing soft tissue infection. Removal of ocular implant. The physician removes the ocular implant from the eye socket. After placing an ocular speculum, the physician cuts and retracts any conjunctival tissue or Tennant's capsule overlying the prosthesis. Any connection between the implant and extraocular muscle or sclera is severed and the ocular implant is removed. Removal of implanted material, anterior segment of eye. The physician retracts the patient's eyelids with an ocular speculum. The physician cuts and retracts the conjunctiva and makes an incision at the juncture of the cornea and sclera, the limbus. The physician removes from the anterior segment the previously placed artificial lens, called an intraocular lens or IOL. It is not replaced. The limbus and the conjunctiva are closed with sutures. Antibiotic or a pressure patch may be applied. Removal of blood clot, anterior segment of eye. The physician retracts the patient's eyelids with an ocular speculum. The physician uses a needle to aspirate a blood clot which has pooled in the anterior section between the iris and the cornea. The needle may enter the anterior segment through the cornea or through the limbus, the juncture of the cornea and sclera. Topical antibiotic or a patch may be applied when the procedure is complete. Removal of corneal epithelium, with or without chemocauterization, abrasion, curettage. With application of chelating agent, e.g., EDTA. In cases of corneal erosion or degeneration, the physician may attempt to stimulate new growth of the cornea's outermost layer by essentially wounding it. The physician removes the outermost layer of the cornea, epithelium, by scraping or cutting it with a spatula or curette, e.g., 65435. Chemical cauterization may be applied. An alternative to cutting or scraping is the application by swab of EDTA, ethylenediamine tetrachic acid, an acid that destroys the corneal epithelium. E.g., 65436. In either case, an antibiotic ointment or pressure patch may be applied once the procedure is complete. Removal of lens material, aspiration technique, 1 or more stages. The physician makes an incision at the juncture of the cornea and sclera, the limbus. The anterior wall of the lens is incised. A probe attached to an irrigating/aspirating machine is inserted into the lens and the lens is destroyed and sucked away. The physician may close the incision with sutures and may restore the intraocular pressure with an injection of water or saline. A topical antibiotic or pressure patch may be applied. Removal of lens material, phaco-fragmentation technique, mechanical or ultrasonic, e.g., phacoemulsification, with aspiration. The physician makes an incision in the cornea or the pars plana. The anterior wall of the lens is cut out. The same type of irrigating/aspirating machine used for extracapsular surgery is used for phaco-fragmentation, but this time the probe is a needle that vibrates 40,000 times per second, phaco-fragmentation, or sound waves, phacoemulsification, ultrasound, that break up the lens. The physician uses irrigation and suction to remove the once hard nucleus, now liquefied by mechanical or sound vibrations. The physician may close the incision with sutures or may design a sutureless self-sealing incision. The physician may restore the intraocular pressure with an injection of water or saline. A topical antibiotic or pressure patch may be applied. Removal of lens material, pars plana approach, with or without vitrectomy. The physician approaches the lens capsule from behind. If the lens is being removed, the wall of the posterior lens capsule is removed and a small suction device is inserted into the lens. The lens material is sucked out. The physician irrigates the area during aspiration. If a retained portion of the lens is removed, a portion of the clear gel in the back of the eye may be removed as well, vitrectomy. The incision is closed with layered sutures. The physician may restore anterior or posterior intraocular pressure with an injection of water or saline. A topical antibiotic or pressure patch may be applied. Removal of lens material, intracapsular. Intracapsular, for dislocated lens. Intracapsular cataract extraction, ICCE, is when the lens and capsule are removed intact. The physician inserts an ocular speculum. An incision is made in the corneal scleral juncture, the limbus. To enhance the flow of fluids in the eye, the physician may punch a hole in the iris before inserting a surgical instrument filled with coolant, cryoprobe, into the anterior chamber. The lens adheres to the cryoprobe as it freezes, and when the cryoprobe is removed, the lens comes with it, e.g., for 66,920. The same technique is used to remove a dislocated lens, e.g., for 66,930. The physician may close the incision with sutures and may restore intraocular pressure with an injection of water or saline. A topical antibiotic or pressure patch may be applied. Removal of lens material, extracapsular. The physician inserts a lid speculum between the patient's eyelids and makes an incision in the corneal scleral juncture, the limbus. To enhance the flow of fluids in the eye, the physician may punch a hole in the iris. Using a method other than aspiration or phacofragmentation, the physician removes the lens in parts, first the anterior lens, then the inner, hard nucleus. The clear, posterior capsule remains. The physician may close the incision with sutures and may restore the intraocular pressure with an injection of water or saline. Removal of vitreous, anterior approach, open sky technique or limbal incision, partial removal. Subtotal removal with mechanical vitrectomy. The physician inserts a needle at the limbus or through the cornea, open sky technique, and passes the needle to the back of the anterior segment where a portion of displaced vitreous humor is aspirated, e.g., 67005. If most or all of the vitreous is extracted, mechanical tools are used, e.g., 67010. When this is done, the physician extracts the vitreous, using a mechanical cutting and suctioning process that may involve a rotoextractor or vitreous infusion suction cutter, VIX. In either case, the aspirated vitreous is usually replaced by an injection of a vitreous substitute or aqueous. Any incision is closed with sutures. Removal of epithelial downgrowth, anterior chamber of eye. The outer lining of the cornea, the epithelium, fails to close properly over the wound, instead growing around to the inner side of the cornea, sometimes continuing its growth to other structures of the eye. Disturbances in intraocular pressure and vision can result. The physician retracts the patient's eyelids with an ocular speculum. The physician locates and excises the extraneous epithelial tissue from where it has spread into the anterior chamber. The original wound may be trimmed and revised. Injections may be required to restore pressure in the anterior or posterior chambers. The procedure may require sutures or tissue glue, antibiotic ointment, or a pressure patch. Removal of secondary membranous cataract, opacified posterior lens capsule and/or anterior hyaloid, with corneoscleral section, with or without iridectomy, iridocapsulotomy, iridocapsulectomy. The physician inserts an ocular speculum into the patient's orbit, and makes an incision at the juncture of the cornea and sclera, the limbus. A small cutting needle and suction device, an irrigating cystotomy, is inserted to chip away the posterior lens capsule. In some cases, the iris must be cut or a piece of iris removed to access the lens capsule. The adjacent membrane, the anterior hyaloid, may also be removed. The physician irrigates the area during aspiration. The physician may close the incision with sutures and may restore the intraocular pressure with an injection of water or saline. A topical antibiotic or pressure patch may be applied.